Hello, hi, it's Dr. Karen Perez again. Today we will be talking about cataracts. So, now the structure of the eye that we'll be focusing on for this presentation is actually the lens, because a cataract occurs when the lens is opaque and the light that shines through the lens, there's an inability for the light to land on the retina. Thus, there is a vision deficit. All right. So normally what you'll see in someone that has a cataract is that it will be, the vision will be cloudy, blurring of the lens. Opaque makes it difficult for the light to land on the retina. Visual acuity is restricted. Normally there's no pain in the eye. So what causes cataract? It's age-related. Approximately 90% of the time, that's the cause of cataract. There's congenital cataract, where you have an infant born with cataract, and that's a different presentation. You also could be caused by ocular trauma, could be infectious or inflammatory condition. It could be disease process such as diabetes, thyroid, parathyroid. It could be atopic dermatitis. It could be use of medications such as corticosteroids. It could be radiation. It could be a protein that's called crystallines that changes in the lens that result in cataract. So what are the risk factors? Aging, smoking, ultraviolet B sunlight exposure, diabetes or metabolic syndrome, prolonged high dose of steroid use. If someone have a positive family history of cataract, it could be poor lifestyle habits such as not exercising enough, not having a proper balanced diet, and it also could be alcohol consumption. So, assessment as a practitioner, what would you be looking at? Or what will, as in the subjective, what will the patient tell you? One, cataract, there's no pain. So they may deny pain. They may tell you that they notice that the vision is getting progressively worse. In addition to that, they may change glass frequently because they may test their eye. They may get this glass because the vision is getting worse. They get another glass. So that's one of the things, or glasses. So that's one of the things that you will see that will change, or that they'll complain of, that their vision is getting progressively worse and they're changing glasses, more frequently than the norm. So, typically, it is bilateral, but most often you will see asymmetrical. So nearsightedness will occur before the cloudiness of the vision. And nearsightedness is when the individual have to hold the object up closer to see. So problem with night driving, reading road signs and fine print. They will also complain of decreased vision that may result in either them falling or injuring themselves, or even the cause of accidents. So there are subtypes of cataracts. So there is a nuclear cataract. This is characterized by significant nearsightedness. And so if individuals have issues or complain of nearsightedness, it could be that they have the nuclear cataracts. It could be cortical cataract. Cortical cataracts do not significantly impair the vision. Now, with posterior capsular cataract, now in this, the subscapular haze and severe glare in bright light. That's one thing they will complain of. It is strongly associated with steroid use, and in addition to that, progressive much faster than the nuclear form of cataract. So as a practitioner, what will you be assessing for? Visual acuity test. You'll do that. You'll test for their peripheral vision, central vision. You'll do the Salin chart. A fundoscopic examination may be done, that which will reveal altered red reflex. The lens would look cloudy. In an advanced stage, the pupil appear white or lunar. The diagnostical study that was done by the ophthalmologist, because in the primary care setting, practitioners does not necessarily treat eye disease. This person would need to be referred. So in this case, as within cataract, do the assessment, yes, in the primary care setting, but this person would need to be referred. When they go to the ophthalmologist, they may do a glare test, a contrast sensitivity test. They may do a slit lamp examination or a macular function test, in addition to others. Now, one of the things is that macular degenerative disease and cataract, sometimes students get those confused. One of the things, cataract and macular, they're slowly progressing. However, with macular, it is central vision that is lost, whereas in cataract, you can see that the entire vision is kind of blurry. Another thing with cataract, it is a lens that is affected, but in macular degeneration disease, it's a macula in the eye that is affected. So make sure you know the difference between cataract and macula. They are both slowly progressive disease, however, differ based on the subjective data that the patient will be giving you and also what you'll be observing during your examination. So there are some assessment tools. We have the lens classification system 3 tool. So in this, what they're looking at, it consists of 6 slit lamp images for grading new clear color. Also, it looks at the new clear opalescence or the 5 retro illumination images for grading cortical cataract, and 5 retro illumination images from grading posterior subcapillary cataract. So most of the time, this classification system will be done by the ophthalmologist. Then there is a CAT Quest 9S5. The aim of this questionnaire is to establish what difficulties a patient have in their daily life due to impaired sight. Then there is the Visual Functioning Index 14. It's a brief questionnaire, and this is designed to measure functional impairment in patients due to cataract. So the scoring for this is between 0 to 100. So if the patient score 100 on this functional index, this is saying that they're able to do all their activities. If they score a 0, it indicates that they're unable to do their activities because of vision impairment. So, what is the management? Now, there is no medication that can prevent or cure cataract. Okay, so most of the time, what will be done is actually cataract surgery. What they will do is extract the lens and put an artificial lens in. Now, they do have surgery, same-day surgery, or surgery that takes place in an outpatient setting. Now, look at this graph here, or this picture here. So here you have the lens capsule, and inside here you have the clouded lens. During the surgical procedure, they will remove the lens, and then they will place an artificial lens on the inside. So post-operatively, as a primary care provider, you may see this person in your facility or your clinic, but most of the time after surgery, they would see the ophthalmologist. So topical antibiotic and sometimes eye steroids underneath the direction of an ophthalmologist would be given. So when to consult, refer, or to hospitalize, all patients with cataract should be referred to an ophthalmologist for eye assessment, because as a primary healthcare provider, that's not your responsibility per se to take on the full total care of someone with a eye disease such as cataract, because it's a specialized healthcare issue. Prevention and screening. So there's no definite measure to prevent cataract. It's a slow progressive disease. So Screening for cataract is a part of every routine eye examination, and it's done after age 40 to 50. Follow-up, course of action. So post-operatively, at about day 1 to 2, they'll follow up with the ophthalmologist. Then in 1 week, then they will follow up, and then in 1 month. Now, this individual may need glasses, but change in prescriptive glasses is determined around 1 to 3 months after the surgery. So again, they don't normally get glasses immediately after the surgery per se, but it's between 1 and 3 months. So complication varies widely. They could, be blind. They could lose their delay in vision recovery. They could have visual discomfort, retina detachment, glaucoma, hemorrhage, infection post-operatively, lens malposition, or dislocation could occur. So special consideration. Disease that influence the decision for surgery is if this person may have cataract, yes, but do they have macular degenerative disease, or do they have diabetes, or have hypertensive retinopathy? That would influence the decision for surgery. In addition, medication that can affect the eye during surgery is our alpha-1 agents such as our Tamsuline. In addition to that, the reason why alpha-1 agent will affect the eye is because they can cause intraoperative floppy iris syndrome. So again, normally they will stop this medication before surgery because it causes intraoperative floppy iris syndrome. So here are my references. I hope this video was very helpful. Please make any comments in the comment box below. Thank you, and please stay tuned for more interesting videos.